Good morning, everyone. We are going to give it just a minute to see who else joins us. We're missing a few. So let's just give it a minute and we will move forward. They're coming. Hang on. All right, still missing a few. Let me make sure I didn't miss anybody. Dominique, Kevin, Michelle, Justine, Nancy. Am I missing any of you? All right. Let's move forward and maybe they'll join us. I've only had 2 people in this particular class take the test so far. It does close tomorrow night. 1 minute before midnight, just so you know. I am having a tutoring session today at 3 o'clock on campus in room 202. I sent that out last night. If you cannot make it, don't worry about it. I will record it and then send it out to you guys. Not a problem. Pretty much everything that we went over last week is what the review will be. I'm not going to do anything too different at the school, except physically show you some of the stuff I've been talking about. So if you can come, that would be great. If you cannot, don't worry. We'll be in room 202 at 3 o'clock today. I plan on doing another live session before our next test as well, since now we are getting into high risk OB, talking about things that can happen during a pregnancy. So just so you know, that's what we're starting to talk about today. Our next test will be week 9 on 20, 21, 23, and 24. I know that that's not something you want to hear today, but let's just get through today's test. Do you have any questions for me? Anything that has come up that you don't get, I need to explain. Anything that I need to go over for this number 2 test? Overall, people have done well so far that have taken the test. But overall, I would say people are doing well. A few not, but the majority doing okay. So I thought I would, thank you, Carla. I thought I would just let you know that I am available for questions. I don't have any open appointments today because we're going to be at the school. So if you need me or you're confused about something, let me know and we'll try and work through it. One last call. Nancy, are you with me? All right. Just checking to make sure I didn't miss anybody. All right, let me tell you, today we're talking about chapter 20. We are starting to get into high risk OB, more complications. That's all about your test 3, about what goes on in OB. That is a complication. Now, if you were to look in chapter 20 in your book, you would see probably 60 different conditions in chapter 20. We're not going to cover all of those. We are only covering 3: cardiac, diabetes, UTI. That is all we're talking about. Just so you know, cardiac is not in the ATI. So everything that I would be asking you is on the outline for cardiac. Everything that could be asked is on the outline for cardiac. Diabetes is in chapter 9, but the majority of what I would be asking, I'll let you know. As we go through this chapter, I will be telling you to highlight different things because you're likely going to see it again. People, we're in week 6. You're doing well. You are doing very well. Are you very proud of yourselves? You should be. You've done well. So if you should need me, there is no reason to fail this class. If you are struggling, please let me tutor you through this and help you. All right, let's pull up chapter 20. I am going to let you out a little early today because I'd rather have your focus be on getting through our test right now and not worry so much about this at this moment. So I'll be letting you out probably close to about 9 or shortly thereafter so that you can devote your time to studying for this test. All right, do you see, let me make sure that you can see chapter 20 big. All right, can you see chapter 20? All right, thank you. So I've done a lot of high risk OB. That means that we had moms that were trying to hang on to their lives or trying to hang on to their baby or both. A high risk pregnancy is one in which a concurrent disorder, which could be cancer, diabetes, renal failure, all kinds of different conditions. A pregnancy-related complication, gestational diabetes, preeclampsia, or external factor jeopardizing the health of the woman, the fetus, or both. Believe it or not, there are lots of people who are trying to hang on to their own health as well as a baby. We are talking more about cardiac today, diabetes and UTI. If you were talking to a high-risk pregnant cardiovascular patient, cardiac, what is objective data that we would want to get on her when we're doing our assessment? What would be important for us to know? Any ideas?
Her diet?
Yeah, for sure. We could talk to her about her diet. We could do vital signs on her. We're going to get baseline vitals. And every time she comes in, we're going to do vitals in that same position. She was sitting in a chair. If she was lying down, it's always going to be the same. So we can get baseline and we can figure out, okay, where are we going from there? Diet is important. Also weight. If she starts gaining weight, what is she gaining weight from? So we are going to be asking about that. Is it normal to gain some weight? Yes, 25, 35 pounds in pregnancy is what we want you to gain. However, if it's too rapid or too much, then we worry about other things. Now, subjectively, we're going to ask her, extent of your edema. I noticed that your legs were swollen. How long have they been like that? When you put your feet up, does the swelling go away or is it still there? What is your level of exhaustion? Are you suffering from fatigue? Because fatigue is one of the first signs of heart decompensation. So, which we'll go over in a little bit. Do you have a cough? Yeah, I've got a dry cough all the time. Okay, that could be one of the first indications that we have left-sided heart failure, pulmonary edema. Do you feel like your respirations have increased or that you have tachycardia? We're going to do an ultrasound to see if the amniotic fluid from intrauterine growth restriction and or poor fetal heart tone variability is happening. Because don't forget, with a cardiac patient, it does affect baby because of the placenta. Is the placenta giving the baby what it needs? Is there enough blood getting to the baby? If not, then we got a problem with our baby. They are usually very small. So these are some of the questions that we want to ask. Get baseline vitals, talk to her about diet, and get a weight. Cardiovascular disease complicates only 1% of pregnancies, but 5% of maternal deaths. Believe it or not, women do still die in labor all around the world. Now, in a third world country, you might say, okay, that could happen because they don't have prenatal care or something's happening. However, the problem with cardiac patients is you get the peak of your increase of blood around 28 to 32 weeks. Now, what do we worry about is that shift. Once she delivers, can her heart handle that shift? In that first 5 minutes of delivery, if a mom has got cardiac issues, this is when something could happen. I already shared with you about that patient that weighed 500 pounds, told don't get pregnant. She did. 10% survival rate. She did not survive. She died that night after having her baby. Daddy's left with a NICU baby and a 2-year-old, no mommy. So I had a patient, or not a patient, a student in my class yesterday that shared with us that she was a cardiac patient, a severe cardiac. Matter of fact, so severe that she has been told, you may not have any more children. They diagnosed her during the first pregnancy. She was having all kinds of cardiac problems. They diagnosed her and she almost didn't survive the first pregnancy. The second pregnancy, she did get pregnant, she was telling us, and had multiple problems. Almost didn't survive that. As a matter of fact, had to have a C-section for both. They didn't want her in any kind of pain, no kind of labor, no nothing. She said, I can't have any more children because the doctor said we won't be able to pull you through another pregnancy. Your heart won't handle that shift. It won't handle the increase of the blood. It was very interesting hearing her story yesterday. She's one of my only a couple of students that I've had that have had severe cardiac issues. One other student that I had was when we were on campus in class. And she scared me all the time because she used to come up the stairs to come to class in room 200. And I said, girl, friend, please only take the elevator. You're exerting too much on your heart, because we talk frequently about this heart thing. And she said, okay, I will. And she finally did deliver and did all right, but it's always scary when you have a cardiac patient. I gotta tell you, I also had another student that said to me, when I was teaching OB and PEDS, I was teaching PEDS class about cardiac issues with children. And one of my students said to the cohort, well, if any of you would like to come to my house and practice doing tube feedings or caring for a child who has a lot of needs, come to my house. I have a little boy that was born with cardiac problems. So she told us the story that when her baby was born, they already knew before the baby was born that he was going to have cardiac issues. He was going to need to have a heart transplant to survive. Well, she was devastated on this, and so was her husband, because she knew that a baby was going to have to die somewhere to give her baby a heart. Her baby was about 3 weeks old, and a baby did die, and the parents donated that heart to her baby. There was a good match, and so they lost their baby, but my student said, we were so grateful to have a heart for our baby. Our baby never came home. He was in the hospital at Primary Children's until he was 18 months old. 3 days, they said, okay, he can go home in 3 days. She said his heart was, his body was accepting the heart. Everything looked so good. The day before he was supposed to finally be able to come home, a nurse walked in the room, gave the wrong medication to the wrong child. He had a major stroke and went into cardiac arrest. That heart failed. Now he has to have another transplant. He also had a stroke that left him right side paralysis. He's 18 months old. And so she said, would it be all right if I brought him to the school? I said, I would love it if you would bring him to the school and let him tell us his story. He did come. He finally did get, when he was, I guess, 4 years old, another heart, and it was rejecting. He was not a candidate for a third. So before he came, she said every night we say prayers with him and we kiss him goodnight, knowing that one night he will not wake up. We've been told by our doctors at Primary he's not a candidate for a third heart. And so we know that he will not survive. But he came in and he was kind of bouncing, which scared me to death. Like, don't do that, don't do that. But he was so excited, and he stood in front of the room with his mom. He lifts up his shirt to show us his scar on his chest. And he said, I have a heart, but it doesn't work too good. And he talked about basically his mortality. He talked about, um, I'm not going to grow up, but you know what? I'm going to see God one day. And he talked, oh my gosh, there wasn't a dry eye in my classroom. Um, he did have a major stroke. It was affecting his right side. He was the sweetest, cutest little boy ever. The saddest part of that whole story was my student said that my parents told me because I was engaged to my husband and one thing led to something else and I got pregnant before we got married. My parents told me that the reason that I have a little boy with heart problems is because it was God's way of getting back to me that I had done the worst thing ever. I said, no, 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 no. God doesn't work like that. This is not your fault. This was an anomaly that your baby had. This is not your fault. We talked for a long time. I stayed in touch with her. I'm sure by now her little guy has passed on, but he had a great attitude. He had a great mom and dad that loved him. He did have siblings that helped take care of him. He was full care, but just, oh, gut wrenching it chokes me up even to think about it because when he came in, it was just like a piece of heaven in the room. Anyway, I got to move on. So if you have stories like this, if you have experiences like my student yesterday sharing with the cohort about her experience with cardiac problems, it's pretty gut wrenching. We use the New York Heart Association criteria but you don't need to know what it is or memorize that. You don't need to worry about that. Now, I do want to spend the next 25 minutes with this doctor. He is an oncologist that specializes with pregnancy. He deals with all pregnant women that have cardiac disease. We think that, it may be only 1% that you hear about, but when you work high risk, you think it's so much higher because that's what you deal with. He's got some great stories that I'd like you to listen to. He's in London, so don't worry about the name of the hospitals or whatever, but he does have some good videos. He's got some good scenarios that he goes through. He talks about medications. You're not going to get anything on your test from this. It's strictly educational, but he does a good job explaining. He does tell women that, because of your cardiac disease, it is possible that you will not be able to have children. He even has told some moms that are pregnant, you need to have a therapeutic abortion. You need to stop the pregnancy to save your life. You cannot get through this pregnancy like this. That's pretty gut-wrenching to be told something like that. My student yesterday said when her doctor told her, you can't have any more children, I'm sure that was gut-wrenching for her and her husband. But at least she has 2 healthy children and she will live to grow up to watch them grow up. So let's watch this. It's about 25 minutes and then we'll take a break.
For concentrating on heart disease and pregnancy is shown in the latest and previous surveys of maternal and fetal mortality. So it's now the Embrace studies that come out. It used to be the mortality in maternal and child health, but they've changed the name and they've changed the base to Oxford. But this graph really explains well why we worry about the heart. So as you're all aware, over the last however many years, certainly the last 100 years, maternal mortality has dropped from very high levels to very low levels. So that mortality now is really very unusual for a mother to die during pregnancy. And a majority of that reduction in mortality, certainly in recent years, has been a reduction in the direct causes of maternal mortality. So things like the management of preeclampsia and eclampsia have improved, the management of sepsis during pregnancy. However, the management of the indirect causes, or the mortality from the indirect causes of mortality during pregnancy, haven't changed to a great extent. And you'll see on this graph that they've really stayed the same. And the commonest cause of mortality during pregnancy, the indirect cause of mortality during pregnancy, is cardiac causes. So the first bar in this graph is a concoction of unusual causes. But the second bar, which is the main single cause of mortality, is cardiac disease. And that's why we concentrate so much on managing women with known cardiac disease during pregnancy and trying to pick up women who develop cardiac problems during pregnancy. And we see both. And the reason for that is because of the physiology of the heart during pregnancy. So during the pregnancy, during the whole pregnancy, you have to increase your cardiac output. A woman has to increase her cardiac output by about 40 to 50%, and even more if she has a twin pregnancy. A woman does that by increasing the stroke volume of her heart, but primarily by increasing her heart rate. So a heart rate of 100, 110 during pregnancy is not particularly unusual. It may cause palpitations, for instance, which is one of the reasons women will come and talk to you about a potential cardiac symptom during their pregnancy. Palpitations are very common during pregnancy. The blood pressure will also change. So during pregnancy, during the first trimester, the blood pressure tends to drop. Second trimester, it starts to plateau off, and in the third trimester will go up. And in some women, if they've got pre-existing hypertension or they're prone to getting hypertension in the future, then hypertension will become quite a significant problem during their third trimester. And of course, there's women who develop preeclampsia who will become hypertensive. So we have to bear that in mind. A woman, however, will drop their systemic vascular resistance during pregnancy, which is the reason the blood pressure drops during the first trimester. And that's a good thing for many cardiac problems. So many cardiac problems, such as mitral regurgitation, are treated by vasodilatation. If you're going to drop your systemic vascular resistance as part of the pregnancy, then that's a good thing for something like mitral regurgitation. It's equivalent to taking an ACE inhibitor, for instance. So we'll skip that. And then, of course, during labor, there has to be very rapid increases in cardiac output. And this could be a big problem if you're unable to produce that increase in cardiac output. So during contractions in particular, the cardiac output needs to increase almost double during the second stage of labor. And towards the end of labor, then there will be an issue with loss of blood potentially. So there are big fluid shifts at the point of the baby being delivered in the few hours afterwards. And there are some cardiac conditions that cannot cope with those fluid shifts and changes in volume. So you can see there's potential for lots of problems during pregnancy if you have pre-existing cardiac disease. So I'm going to start off just going through the important, serious conditions of the heart that can lead to problems during the pregnancy. So these are the ones which are associated with a potentially poor outcome. And the first is outflow tract obstruction. And all of these, you'll see, are conditions where you cannot increase the cardiac output. So these pictures show you patients with aortic stenosis. You'll see the first image on the left is a bicuspid stenosed aortic valve. Then you'll see an echo picture on the right there of a tightly stenosed aortic valve. And below you'll see pictures of a patient who had significant mitral stenosis. And whether it be inflow obstruction or outflow obstruction, it's really difficult to increase your cardiac output. And as a result, patients with these conditions, if they're significant, do very poorly during pregnancy. What we know is that if you've got significant aortic stenosis or significant mitral stenosis, it's better to treat those before embarking on a pregnancy. And we'll talk about preconception advice a little later in the talk. But if these appear during pregnancy, they're first diagnosed, and we see, particularly in the clinic I run at the Royal London, where we have a population that's changing all the time, and we have groups of women who've come from the developing world, we will often pick up unknown valvular disease during the pregnancy because these women haven't had checks when they were at home say in South Asia or South America, for instance. And if we pick up significant aortic stenosis or mitral stenosis, it may be that you'll have to send these patients for an intervention during their pregnancy. We occasionally will pick up a woman at an early stage in pregnancy with severe aortic stenosis, and then we have to have a discussion with the woman and her family about the potential problems and the possibility of having a termination rather than going through the pregnancy with a high risk. But if we pick up these lesions in late in the first trimester or in the second trimester, or the woman doesn't want to contemplate a therapeutic abortion, then there have been cases, well-documented cases, of intervening even on aortic stenosis and sending a woman for an aortic valve replacement and the baby surviving. With mitral stenosis, there's a very good body of evidence that you can do a successful balloon valvuloplasty during the pregnancy, and this is done most frequently in the developing world. So if you went to a cardiac unit in Bombay or Delhi, they would be expert at doing this. We will do it only maybe once a year or less in our unit, but you can get a very good result with a good outcome for the fetus as well. Perhaps the most serious condition if you're pregnant is if you have significant pulmonary hypertension. So women who've got known pulmonary hypertension, whether it be as a result of a primary condition, as shown here, for instance, on the left, or as a result, so this is primary pulmonary hypertension on the left, or as a result of a large VSD, as seen on the right. If they've got significant pulmonary hypertension, their maternal mortality is at least 50%, if not more. And so we would counsel very hard to avoid pregnancy if you have these known conditions. And ideally, these women are brought through initially the pediatric service and then an adult congenital or an adolescent congenital heart disease program, and someone would have spoken to them about the risks of pregnancy long before they get to the stage where pregnancy would potentially be an issue, and they will be using effective contraception. But having said that, the drive towards wanting to be a mother is so great, and occasionally these conditions haven't been diagnosed properly, especially in women coming from abroad, and they will present in pregnancy, with a pregnancy. And in those cases, if they come early enough, we would strongly recommend therapeutic abortion, but occasionally they would decline. And I've certainly looked after one woman who had significant complex congenital heart disease and was pregnant, didn't want to have an abortion, and sadly lost her life as a result of that. So it's a really serious condition. The next section is discussing patients with reduced left ventricular function. Many of these patients at this age group, if they do have reduced ventricular function, will have a dilated cardiomyopathy. And again, if you have a woman of childbearing age coming to our clinics, we would talk to them about the risks of pregnancy at an early stage. And they would have, depending on the severity of left ventricular dysfunction, they would have this very significant risk of morbidity and significant mortality if they were to get pregnant. So some of these will be patients with pre-existing left ventricular dysfunction. Sadly, more often now, we're seeing patients who have had significant myocardial infarcts prior to getting pregnant. So we see a group of women in their early 40s who are embarking often on first pregnancies because of career and so forth, who have had myocardial infarcts in the past. So a case that comes to mind, I looked after a young woman who, I think she was 28, firstly when I was a registrar, and then at the early stage of my career, which is now as a consultant, which is now nearly 20 years long, who presented with a large anterior infarct. She came from a family with a terrible history of early onset coronary disease. She was a heavy smoker. She ate terribly and had a very high cholesterol. And she presented with this big anterior infarct. And she did remarkably well. She had an intervention to her left anterior descending artery. I looked after her for a few years, and then she was discharged from clinic. And the next time I saw her was about 15 years on, and she presented age 42 with her first ever pregnancy. And she was incredibly excited about being pregnant. And we re-echoed her, and her ejection fraction was still around about 30-35%. So we counseled her and explained to her the risks of progressing with the pregnancy. She was determined to have a baby. She felt it was her only ever chance. We never turn patients away. We run clinics both at the Royal London and at Queen's Hospital in Romford. And when we counsel women about the risks of their pregnancy, we always say, if you decide to get pregnant, or if you don't wish to have a therapeutic abortion, we are more than happy to look after you, and we will see you on a very regular basis and take you through the pregnancy. And she decided she was going to go ahead with the pregnancy. At that stage, it was early pregnancy. We withdrew her ACE inhibitor because an ACE inhibitor is strongly contraindicated because it'll affect the fetal kidney. We cut back her diuretics completely. She wasn't on very much, in fact, at that stage. We got her onto nitrates. She stayed on aspirin, and we beta-blocked her, all of which is safe during pregnancy. And she did really well during the pregnancy. She was starting to get a little bit breathless. And then in the last week or so of pregnancy, and then just after term, she went into pulmonary edema. But we treated that with diuretics. We got it through, and thank goodness she was fine. And it was just a wonderful moment when she came back to clinic 6 weeks postpartum. And this woman I'd known for a long time with a baby, and she was just so happy. So although it's risky, getting a woman through this can be incredibly satisfying. The other group of patients that we see with poor left ventricular function, 1 in 5,000.
Am I the only one who's lost?
Severe ones tend to be picked up right at the end of the pregnancy, late in the 3rd trimester, and often early in the postpartum period. So if you see a woman who's postpartum, maybe two weeks postpartum, who's suddenly become very breathless since she's had the baby, or even a few months postpartum, just think this may be quite significant. And occasionally we will pick up women with really very severe left ventricular dysfunction. One that comes to mind is an Albanian lady who's a late booker at Queen's Hospital, was admitted very breathless at about 32 weeks, had crackles in her chest. She had an echo done that day and showed a 15% ejection fraction, so a really very poor left ventricular output. And they decided, the obstetricians decided they were going to deliver her, because in an obstetrician's mind, if you've got a woman who's ill, the first thing you want to do, as you do say in eclampsia, is you want to get the baby out. And I actually went into theatre and said, stop, because the problem with these patients is that they go off really big time when you deliver them, and delivering her in a DGH without tertiary cardiac facilities was potentially a disaster. And we managed to get her transferred to the Royal Brompton, who have an arrangement with Chelsea and Westminster, so they can deliver in their cardiac unit. She was delivered, she went into cardiogenic shock almost immediately and was put onto ECMO, which is extracorporeal oxygen transfer. So she basically had an artificial heart system keeping her going. Sadly, she was on ECMO for a period of time. She then had a left ventricular assist device put in, but she became severely septic and sadly lost her fight for life about 6 weeks postpartum, which was a shame. But on the other hand, we've seen women with very severe cardiomyopathies like this who've got through, and at least a third, if not a half, will recover, and their left ventricular function will go back to normal. We don't completely understand the etiology and the process, but it clearly seems to have something to do with estrogens, and then the stress of pregnancy on top of that. But if you can get them through the initial period, they will recover. There was an excellent case of a woman with a twin pregnancy who developed a relatively early peripartum cardiomyopathy. She went to Queen Charlotte's, was delivered, and then had a left ventricular assist device attached, and over the first 6 months postpartum, her heart recovered. So she had the LVAD, kept her going, and her heart recovered. We tend to advise that there's a high risk of a subsequent pregnancy, but there have been many women who've recovered and then had a further pregnancy without serious problems, but it's clearly an increased risk. The next group of patients that we're concerned about are patients who've got problems with their left ventricular, with their aorta. So the classic case would be someone with Marfan's, family history of Marfan's, or with some other similar connective tissue disorder. But Marfan's is the one we know most about. And what we know is that during pregnancy, even with a normal aorta and no Marfan's, there's a slightly increased risk of aortic dissection. It's the pressure that's put on the aorta. But if you have a known problem, particularly Marfan's, the significant thing to look for before the pregnancy is whether the aortic root is dilated. And the greater the aortic root is dilated, the higher the risk of a dissection during pregnancy. And we worry about these patients a lot. We do serial scans of their aortic root, usually with echo, but with an MRI at the beginning of pregnancy. An MRI is safe during pregnancy. But even with a patient who has a normal aortic root but no Marfan's at the beginning of pregnancy, there's an increased risk of dissection. So we counsel the patients very carefully. If they're known to have a dilated root and they're keen on pregnancy, we would counsel them to have the aortic root replaced before they embark on pregnancy. If they have a successful root replacement, with some caveats, then the risk is much less than it would be if you have an unreplaced root that's dilated at the beginning of pregnancy. So patients who present with severe chest pain during pregnancy need to be dealt with urgently. We then worry a great deal about patients with prosthetic valves, whether it be mitral or aortic. We see the occasional right-sided valves, but that's very unusual. And the reason we worry primarily is if they've got a mechanical valve. Previously, there was a lot of concern if you have a tissue valve that it will age and deteriorate very quickly as a result of pregnancy. There's some debate about whether that's the case or not. But on the whole, if you've got a young woman who's having a valve replacement, there's a concern about putting a tissue valve in because they may need to have a whole series of operations during their life. Although there may be an argument, and often it's made, and a decision is made to put a prosthetic valve with a tissue prosthetic valve in initially, allow them to have a family, and then put a mechanical valve in after they've decided they've finished their family. And the reason for that is illustrated very clearly and rather tragically by this case. This is the post-mortem specimen from the case that made me interested in pregnancy and heart disease. And I'll tell you a little about this patient. She was a young woman, about 19, had a valve replacement for congenital mitral valve disease when she was about 12. And they put a small valve in because she was very small. She was only about 4'10". Even when we saw her, maybe 5 foot when she was looked after during pregnancy. So she was a very small girl, and she had a small valve put in. And this valve was put in at St. Mary's, and she lived in the King George area. And this occurred only a few months into my consultant post. And when she got pregnant, she was seen in the anticoagulation clinic where she was usually managed, and they swapped her to unfractionated heparin. It was before the days of low molecular weight heparin. She was run on unfractionated heparin. They monitored it as best they could. She said she was going to St. Mary's to have her checks of her heart, but she wasn't because the bus fare was too much, and her boyfriend decided they couldn't afford it. And as a result, at around about 34 weeks pregnant, she became very breathless. And she was seen by the GP. GP thought she had pneumonia. It's quite understandable. And she then had PV bleeding. And she came in as an emergency, and she had a placenta previa, and she was bleeding heavily. She was clearly very breathless. She was seen by the medical registrar on call, who again thought she probably had pneumonia, hadn't seen pregnant women with heart disease before. And she went for an emergency C-section. She had the emergency C-section, and she went off immediately. She was woken up, went into crushing pulmonary edema, was re-anesthetized, re-tubed, and I was called to see her. And she was an extremis on ITU. And I TOE'd her at that time, and the valve had a big lump of clot. The valve was neither opening or closing, so it was stuck half open. There was severe mitral regurgitation and stenosis, and not surprisingly, she was in a terrible way. We took her to London Chest, but we lost her. Perhaps in hindsight, we should have given her thrombolysis, but it was the first time I dealt with such a case. And you can see here, you can see where the mitral valve is, and there's a big lump of clot and pannus around it, so this has been building up over some time. And it was at this point I realized that we needed a local service to see pregnant women with known heart disease throughout their pregnancy. And we've seen numerous women now since then with prosthetic valves, mechanical prosthetic valves. And what we used to do is we would stop their warfarin, because warfarin is teratogenic in the first trimester. We'd give them low molecular weight heparin now for the first trimester, swap them back to warfarin for the rest of the pregnancy, and then swap back to heparin for the last week or two. And we did that for quite a long time. The problem with that is that even during the second and third trimester, warfarin is a problem. There's a high attrition rate of babies because warfarin crosses the placenta and the babies are prone to bleeds into the brain. And so in recent years, there's been a general trend towards using low molecular weight heparin throughout the pregnancy. So if you have a woman who has a mechanical valve, and one or two of you may have that of childbearing age, as soon as they get pregnant, they need to go to anticoagulation clinic. We swap them to Clexane. We measure something called the anti-10A antibody level every other week, and we have a target range, a bit like an INR, and we give them aspirin as well. And a vast majority of our women have done well, but there is a problem. Even if you run things well, there's a risk. This was a young woman, a teacher, with a mitral prosthesis. During her pregnancy, she was on Clexane and aspirin. The levels were ideal, but even so, she presented breathless, had signs of pulmonary edema, and the valve on, this is a normal echo, and it's not opening properly. It's difficult for you to appreciate, but here, on the lower slide, the flow of blood, the velocity of the flow of blood across the mitral valve is very high, and that suggests that the valve is partially occluded. And she'd noticed that the valve had stopped clicking. And then she actually went to another center with tertiary care services available, and she was given thrombolysis. And halfway through the thrombolysis, she started hearing the valve clicking again. And you'll see here on this second Doppler slide, the velocity of blood has dropped significantly back to normal. And the clot cleared. She was managed on warfarin for the rest of the pregnancy, had a healthy child, and has avoided a further pregnancy. So even with Clexane, there's a risk. Now, the group of patients we see quite frequently now, more often than we used to, are women who develop coronary problems during pregnancy. And in many cases, this will present acutely with a first myocardial infarct. And classically, this would be as a result of either a coronary dissection or thrombus in the coronary. And this is a case, lady presented with what is a posterior infarct. She's got ST depression in the septal leads, classic of a posterior infarct. And the treatment for these patients goes straight to the cath lab. Even before we did primary PCI, we would take these patients to the cath lab rather than thrombolizing them. And I'll try and use the arrow here. Yeah, so she's got an occluded circumflex artery due to these appearances are classical pictures of a coronary dissection. We ballooned and stented the whole vessel. One of my colleagues did this and had an excellent result. But more recently, things have changed, and we seem to see more cases of patients with classic, standard atheromatous coronary disease who develop myocardial infarct. This was a young woman. This actually happened about 4 weeks after the Moamba case. Things were not quite like they used to be. And this woman presented acutely to the ambulance service with what is a big inferior myocardial infarct with quite widespread ST elevation. She came to the lab on a day I happened to be there at London Chest. It's difficult to get into a right coronary, but I hope you can make out that just down here, the dye stops and there's an occlusion. So she's got a right coronary occlusion. We put a wire through. We direct stented it. So we put a stent directly there without ballooning it. And the final images were excellent. Unfortunately, this is what happened next. Within a few seconds, so she arrested, went to VF. And we did 3 cycles of CPR on this woman with a 19-week fetus. Unfortunately, we got her back, as we would expect in that circumstance. And she went up to the ward. Having done the clinics, the joint cardiac clinics for a long time, I can actually do a reasonable fetal ultrasound these days. But in this particular instance, I waited for an obstetric colleague to come across to London Chest. And about 5 hours later, he scanned her fetus and the baby was fine. And it was another great example where the patient came back. We'd seen her on and off during the rest of her pregnancy. She delivered at about 40 weeks. She was quite an older patient. She was a 42-year-old, had a previous TIA, in fact, heavy smoker from Dagenham, and she came back with a healthy baby. And again, it was a delight to see. So they're the severe, worrying situations. There are many cardiac conditions that are well tolerated. Leaking valves, as I said, are helped by the fact that you vasodilate. Many of the congenital anomalies like ASDs, small VSDs, are very well tolerated. Hypertrophic cardiomyopathy is well tolerated. Of course, you've got to counsel the woman the risk of the child having this condition, and you need to be very careful about fluid balance around the time of delivery, and most of the arrhythmias. So a lot of women come with arrhythmias, SVTs. We see lots of women with ventricular ectopics. We even see some with heart block and with ventricular tachycardias. Heart block can be paced during pregnancy. I've paced women during pregnancy. My colleagues now tend to do that at Barts for us. That can be done very successfully with low exposure to radiation. And in all our time, particularly the SVTs that worry women, they all worry that this is going to happen whilst they're in labour. And we think because in labour you have quite marked vagal tone, these arrhythmias don't tend to happen as much as you would expect. And in the last 18 years of doing these clinics, I've only seen one woman who's actually gone into SVT during labour. You can give them adenosine very safely, has a very short half-life and causes no problem. So they don't tend to cause a problem. We reassure them hugely. The other issue, of course, is drugs, antihypertensives. We've already said that ACE inhibitors are a risk. Classically, we use methyl dopa, labetalol, but we can very comfortably use the dihydropyridine calcium antagonist, amlodipine, nifedipine. We can use hydralazine. Sometimes you need to use a combination. The obstetricians are great at looking after the hypertensives, and they run their own hypertensive clinic. They don't need us there. So that's usually quite straightforward. The antiarrhythmics, we definitely can't use amiodarone. We can use beta blockers. They're very safe. The data that came out in years gone by about beta blockers was on huge doses in rats, and in practice we use bisoprolol, metoprolol very freely without any problems. They don't tend to cause growth retardation. You can use flecainide during pregnancy if you have to, so we will use that in some cases. And other drugs we need to check individually, but those can be used, and they're the most frequently used. Heart failure drugs, again, ACE inhibitors, the ARBs we can't use, but we tend to swap to other vasodilators like a nitrate or hydralazine. We try and limit the use of diuretics as far as possible. Angina, again, beta blockers are fine, calcium antagonists are fine, nitrates are fine. So we don't tend to have a problem. And when it comes to anticoagulants, we've already talked about clexane versus warfarin, but the antiplatelet drugs, we know that clopidogrel is fine. We've used that because we've had patients who've been stented prior to pregnancy, and we've used clopidogrel and aspirin throughout pregnancy without a serious problem. Obviously, there'd be a concern at the time of a cesarean section, or if they were to have a tear, and you may have to withdraw the clopidogrel temporarily to allow bleeding to stop. And we've seen a few problems with quite significant hematomas as a result. The presentations, these are the things you're likely to see women with who they'll complain of breathlessness. On the whole, we regard breathlessness as a normal part of pregnancy. You've got your diaphragm stented by the fetus, and most breathing in normal times is because of diaphragmatic movement, so they're going to use their intercostal muscles more, and they'll feel more breathless. They're putting weight on, so things become harder. So it can be quite difficult to distinguish between what's normal for pregnancy and what's not. An echo will help with that. Occasionally, if you've got a patient who's acutely breathless, you've obviously got to think of a pulmonary embolus, which is significantly more common during pregnancy. Murmurs. We see lots of women with murmurs during pregnancy, and we try and triage them out of the main pregnancy clinic because almost all women will have a flow murmur during pregnancy. I've been doing it for years, so I can say whether it's a flow murmur or not just by listening, but it becomes quite difficult if they've got a loud flow murmur. So in that case, it's reasonable to refer them, and we will echo them. Echo obviously is perfectly safe during pregnancy. And palpitations, as I said, almost all women will have a degree of tachycardia. Other types of palpitations, particularly ventricular ectopics, are much more common during pregnancy, almost never cause a problem. We reassure the women, and that's the case. We may do an echo to check ventricular function is fine. Occasionally you'll see new SVTs. They often settle down after pregnancy. If not, they can be treated in the same way as SVTs do in other situations. Chest pain, we obviously worry about possible ischemic heart disease if they're very high risk. It's pretty unusual to pick up an ischemic heart disease with angina rather than a myocardial infarct. We send occasional patients for more detailed investigation. We rarely find that they have ischemic heart disease. Chest pain is quite common. Costochondritis is more common. Aches and pains are not unusual in pregnancy, of course. And then dizzy or syncope. That's so common. Fainting is almost a normal part of pregnancy, and it's trying to differentiate between whether it's significant or not. Vast majority of cases, it turns out, it's just part of the pregnancy. So how do we manage these?
All right, and then he talks about clinics that he runs. Let's take a break and I'll see you back about a minute or two after 8 o'clock. All right, everybody come back to me, please. All right, we're going to be talking in a few minutes about right and left-sided heart failure. I know that you've probably had cardiac recently and Kotak, but just as a review, let me do this, show you this. It just runs about 7 minutes. So let's watch this and then we'll
So I
move
really
on.
do try my best to keep up with every comment and suggestion. And the common themes that have between the two and the symptoms that we can expect, because that's really important when we talk about right-sided heart failure and we talk about left-sided heart failure. What we really want to know is what is the problem that it's going to create and what are the manifestations that we're going to see. So before we talk about it, let's run through the heart for a second. So let's run through the blood flow of the heart. So we know that we start here from the superior vena cava, I almost said inferior, superior vena cava and the inferior vena cava into the right atrium, right? And then from the right atrium, we're going to pass through the tricuspid valve into the right ventricle. And I'm making this blue because blue represents poorly oxygenated blood. And this is poorly oxygenated blood on the right side. Now the right ventricle is going to squeeze, and then the blood is going to shoot through the pulmonic valve, out through the pulmonary arteries to the lungs. So let's draw a set of lungs. So here's one lung, and here's two lungs, right? And once it's in the lungs, it's going to pick up oxygen. So it's going to return to the heart through the pulmonary veins, to the left atrium, down through the mitral valve or bicuspid valve, to the left ventricle. That left ventricle is going to squeeze. We're going to go through the aortic valve and out through the aorta to the body. So let's draw our body here. So here we are. Here's our body. So this is important to understand the blood flow through the heart in order to talk about left-sided versus right-sided heart failure. So the terms that you're going to hear left-sided heart failure, right-sided heart failure. The heart truly is not failing. Failing means you just didn't work at all, right? Nothing's happening. It's not that the heart is failing, it's just really not pumping effectively. That's what happens in left-sided and right-sided heart failure. So if we focus on the right side, and I'm going to put an R here for the right so we can make symptoms about that, and then I'll put a left here for the left so we can make some symptoms about that. So just focused on the right side. If the right side of the heart is not pumping effectively, meaning that the ventricle is not squeezing effectively, then what's going to happen? Well, think about the blood flow. So we know that the blood in the right ventricle is not going to get squeezed out into the pulmonary artery to the lungs. So we're going to have a decreased amount of blood that's making it to the lungs, and we're going to have a backup of blood through the right atrium. Because remember, the blood that's in the right atrium is going to empty into the right ventricle. But if that right ventricle isn't squeezing effectively, then the blood's just going to start to back up. So we end up with backup, and I'm going to make an arrow, backup of blood to the body, right? To body, because that's where it came from. It came from the body. So that's one thing. And we're going to end up with a decreased amount of blood to the lungs, because they can't squeeze hard enough to get that blood out to the lungs. And I have all this influx of blood coming to me from the atrium, but I can't squeeze to get it out. So now we're going to start to pump backwards. So one of the things that we see a lot is JVD, jugular vein distension. You see this in right-sided heart failure because as the blood is backing up, it's backing up to the body. And you're going to see those veins bulging because you have an increase of blood that's backing up. As a result, you might even see some edema in this person, in this individual, because again, if you just trace it backwards, all the blood is going to start to pool backwards and it's going to accumulate in the body. Now, if we focus on the left side, and let's delete some of this, it's starting to get a little bit busy. So let's delete our right side since we just talked about that. If we focus on the left side of the heart, remember the left side, so we're talking about here, that left ventricle is, the job is to squeeze the blood out through the aorta to the body. But again, if we're talking about heart failure, that this squeeze is not effective enough, then that means that I'm not going to have enough blood getting out to the body. So instead of it backing up to the body, I actually have a decreased amount of blood out to the body. So to the body. And this is oxygenated blood, guys. So this oxygenated blood, we need that for tissue function, for our own function. So this person's going to be tired, definitely fatigued. We might have decreased pulses, decreased perfusion we're going to see in this individual. And just like we had on the right side, if I can't squeeze effectively to get this blood out, then all the blood that's coming from the left atrium pouring down to my left ventricle is going to start to back up. It's going to back up because there's nobody down here emptying, right? There's no one down here doing the job. And where is it going to back up to? Well, the lungs, right? Because that's where it came from. So if I have blood or fluid backing up to the lungs, then what's going to happen? If you listen to the lung sounds, you're going to hear crackles because we know that's excess fluid. We have fluid overload because we're backing up. dyspnea. This person's going to have a hard time breathing because of all that backup that's happening. So now that you understand where the right side goes, where the left side goes, you know that if at any point in time these ventricles are not pumping effective enough, what the manifestations are that you can expect to happen. So what would be our treatment? So let's write that here, treatment. What's our treatment of choice here? We want to give the patient something to make the heart squeeze stronger, because the problem is it's not squeezing strong enough. We call those drugs positive inotropes. And the big one we always talk about is digoxin. That's a positive inotrope. Now, digoxin works by making the heart squeeze stronger. But in order to squeeze stronger, the heart has to slow down. And that's why we always make a big deal about digoxin, that in an adult, the heart rate cannot be under 60 beats per minute. And we're talking about taking the apical pulse, right? So here, cannot be less than 60 beats per minute, because in order for it to squeeze stronger, it's got to slow down a bit. Think about going to the gym and picking up 80-pound dumbbells, and someone tells you, I need you to do 20 reps. If you try to lift those dumbbells as fast as you can, you're going to fatigue very quickly. But if you slow down, you may be able to do a better job. You can be stronger at it and more effective. And that's the same idea as digoxin. So that's why that heart rate is really a big deal. Now, as you look at these symptoms, you should be thinking to yourself, what do we do to alleviate these things? So at left-sided, where we have the fluid and the blood backing up into the lungs, we've got the crackles and dyspnea. We can end up, of course, with pulmonary edema. Then think about giving a diuretic to help relieve all of that fluid accumulation that we have. And really, this list of manifestations is something to help jog your brain. So
All right, so in talking about left and right-sided heart failure, with left-sided, one thing I'd like you to underline under 4A is talking about mitral stenosis, which is, what is stenosis, by the way? Anybody know what that is?
Hardening.
It's hardening. It's
Narrowing of the,
yeah, that's right. That's right, Elizabeth, you're right. It is narrowing. It is a pathological narrowing of the orifice of the mitral valve. I want you to know that. Also, the last sentence there. With mitral stenosis, to prevent a thrombus, we don't want a blood clot in there. You're going to give an anticoagulant. An anticoagulant. Some people confuse that with an antihypertensive. No, an anticoagulant is what I'm looking for so that we don't develop a blood clot. Now with orthopnea, this is when a mom cannot sleep in any position unless her head and chest is elevated. So how are we going to position her? On her left side for better placental perfusion and with the head of the bed elevated. So the fluid in the lung, especially with left-sided, will go to the bottom of that the lung or the chest and give more ability for gas exchange. That's what we're looking for with her. Now with paroxysmal nocturnal dyspnea, this is when she wakes up in the middle of the night, can't breathe, breathless. That's from pulmonary edema. Once again, put the head of the bed elevated and on her side if you can, especially pregnant. With right-sided heart failure, you do see some of the signs and symptoms on your PowerPoint here, but one thing is a distended or enlarged liver. Have any of you ever palpated a liver? Have any of you been able to palpate a liver? You can do that on somebody that's not overweight and definitely not pregnant. Ascites, when you're talking about ascites, that is the swelling, distension of the abdomen that can happen with right-sided heart failure. They complain of not being able to eat. They complain of GI distress. You may see on the right side distended jugular veins from that backup. They will have peripheral edema. Edema is normal in pregnancy. However, If the swelling does not go away, then we worry about a cardiac issue. Can anybody think of a valve problem or condition that children get that can be worried about as an adult? What about Kawasaki disease? Kawasaki, I don't know if you've talked about that yet in peds. However, it is an acute febrile syndrome that does cause generalized vasculitis. This is a problem with the valves. These children sometimes have to take full strength aspirin, not baby aspirin, but full strength aspirin for the rest of their life to prevent valve damage. Also, rheumatic fever, which is an autoimmune disease, can be a reaction from group B hemolytic strep. This is a problem also with the valves. Could be on long-term aspirin therapy as well. Now, congenital anomalies like the little boy that I was telling you about have congenital anomalies. He was born with a cardiac issue. You can also have women that have babies that are low birth weight. They're premature. Why is that? Because the placenta is not giving them what they need to have. So in that number 6, too much talking. Look under number 6, toward the end. Babies may not respond well to labor. That is because the placenta is not giving them great perfusion. If I were to ask you for a test purpose, you have a cardiac patient, baby is showing late decelerations. What is the cause of late decelerations? If you think of the P, placental insufficiency. Women that have cardiac problems are not giving their babies enough. The babies have lates because of placental insufficiency. Make sense there? With coronary artery disease, he talked about that already and talked about that women, when they deliver, in that first 5 minutes can be critical. That's just when we lose our moms in the first few minutes after, because they cannot handle that overload of fluid. They cannot handle it. With chronic hypertensive disorders, the cutoff blood pressure for OB is 140/90. We're going to be talking more about preeclampsia next week. However, chronic hypertensive, if you are a patient that's chronically had this, pregnant or not, that can also be a problem, especially if the woman is a little bit older in the pregnancy. The baby's at risk for poor heart, kidney, and or placental perfusion during the pregnancy. We're going to treat her with beta blockers. Lots of women that come in that have cardiac or preeclampsia will be on beta blockers like calcium or labetalol, nifedipine, not calcium, but calcium channel blockers like labetalol, nifedipine, that kind of thing. Those are very safe during the pregnancy to take. With venous thrombolytic disease, this is when we can develop a DVT because of stasis of blood in the lower extremities. How would you prevent a patient from developing a DVT?
Blood thinner?
We could do a blood thinner, yeah. What's another way that we could do? Let's say you have a C-section mom that can't get out of bed for 6 days. Yeah, absolutely, absolutely. If she can't get out of bed, you put those pneumatic pressure stockings on. It's squeeze, 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 and that will keep the circulation going. Then after that, dangle her legs and get her moving. With peripartum heart disease, as he's already talked about, there is a note under that says fatigue is a symptom of cardiac decompensation. Please underline that. What if a mom says, I think I'm going to start exercising, so I'm going to run every day. She's got a cardiac patient. Would that be a good idea? No. Best exercise for her is walking, and she's only walking until she gets too tired. Then we stop, and that's why we recommend our cardiac patients walk with someone else, walk with your partner, walk with your mom, walk with somebody, because when you get tired, they're going to have to go get the car. They're going to have to help you sit down. You don't want to stress that heart. The cough is the most significant thing. Heart failure may first manifest itself by a simple cough. It's a dry cough. There's no production, but would be left-sided heart failure where you have pulmonary edema. We've already mentioned the liver increasing in size with right-sided heart failure. Have any of you had an echo done?
I watched
Anybody?
baby.
You watched a baby get an echo done? Are echoes painful? No. It's like doing an ultrasound of your chest. Now, would the fetal size be any significance with a cardiac patient? Yes, because that placenta has not been perfusing well. We're going to have a small for gestational age baby. The baby's going to have a poor response to labor. And that's due to poor oxygenation, not getting what it needs from the placenta. We want to promote rest. One of the questions on the homework was, how many rest periods do we recommend? Well, that would be 2 rest periods and a good night's sleep. If you have other children, you're going to say, hey, mom's going to go lay down for a couple hours. Don't tear up the house, okay? You can't do that. It's not easy. So this is when you might need to hire help or have family members come over. We're going to talk to her a great deal about diet as well. What is something that we're going to ask our cardiac moms to eliminate or decrease in their diet?
Salt.
Salt, for sure. Does any food have sodium in it? Pretty much everything. The easier question was, what doesn't have sodium? Almost everything. If you go to In-N-Out for lunch, between your soda fries and that burger, you've had enough salt for 2 days. So with cardiac moms, that can be a problem for retaining too much fluid, which is going to compromise their heart even more. If you go to your medicine cabinet and you pull out any drug that you have, it's going to say, do not take while pregnant. This is what the pharmacies do to release them from lawsuits. Do not take if pregnant. Now, would we tell a mom to stop all of her medication? No, it depends. We want to weigh, does the benefit outweigh the risk? Nifedipine, safe. A lot of medications are safe during the pregnancy, but she would talk to her OB about that for sure. What medications are okay? Like digoxin, as they mentioned in the video. What's the cutoff heart rate again? We don't want our heart rate to be under what?
60.
Right, 60. If it's above 60, we're safe in giving digoxin. Penicillin is all right to give, especially if she has a history of rheumatic fever. Penicillin is safe in the pregnancy. We can give ampicillin, amoxicillin, or Clinda. What we're trying to do there is to prevent a streptococcal infection from invading that placental site. When that placenta comes off the uterine wall, she could possibly get an infection in that area of the uterus. So as a prophylactic, they may give her ampicillin or amoxicillin. What we don't want to do is get an infection that would create a subacute bacterial endocarditis. That would not be good. We're going to educate her on infections. Every time she comes in, you're going to dip her urine. She's going to leave you a urine sample. 3 things we're looking for: ketones. Are you developing a UTI? We're looking for protein in the urine. Are you developing preeclampsia? We're looking for glucose spilling in the urine. That's a great medium for getting an infection. Are you eating too much glucose? That would be a huge problem to get an infection. What does infection do to the heart? Yeah, Tracy, good. It does increase the heart rate, exactly, which is going to compromise. So we want to avoid infections. Now in OB, we have antepartum, intrapartum, postpartum. Antepartum is when she is in the pregnancy itself. Intrapartum is when she's with us in the hospital in labor and delivery. How are we going to position her? We're going to keep her on her side, whether it's the right or the left. We are not going to keep her on her back, of course. We don't want supine hypotension. We are going to elevate the head of the bed for easier breathing for her, especially with left-sided heart failure. We're going to give her an early epidural. We don't want any, we don't want her heart working anymore because of the pain. We're going to let that baby labor all the way down to the introitus. Then we're going to put a vacuum or a forceps on and gently pull the baby out without mommy pushing. Now in postpartum, we're going to assess for heart failure. One of those would be fatigue. We know that she's going to be trying to adjust with that shift in her blood. We may have to give her an anticoagulant and digoxin therapy in postpartum after she delivers. Give her a stool softener, because one thing we don't want her to do is sit on the toilet straining and straining in a vagal response, causing that heart to work even more. So we may give a stool softener. You need to be careful giving Pitocin. Pitocin can actually increase her blood pressure. So all of her IV medications will be on pumps. We want to be sure she only gets so much fluid an hour. Then with the intermittent pneumatic compression boots, have any of you ever worn those? You have, Jill?
The SCDs.
Mm-hmm.
Yeah, after my C-sections, I wore them.
Yeah, very common after a C-section. Some women like it because it's a massage on the legs. One of my students yesterday said she had worn them and it was almost claustrophobic. After a while, women are saying, get these off me. But a lot of women, if they can just relax, they really like that. Did you like them, Jill?
Yeah, I thought they were nice. They felt good. I
Yeah,
didn't mind them at all.
yeah, a lot of women like those. All right, now we have talked about cardiac. Everything I'm going to ask you, we've talked about already. Now we're going into diabetes. Diabetes actually is in your ATI chapter 9. So if you would like to review that there. One of the problems with diabetes is we're trying to balance. We're trying to not have her go into a hyper or hypoglycemic situation. There are different classifications of this. One, who gets type 1, by the way? Who gets type 1 usually?
Younger, like kids.
Kids, that's right. It used to be that if you got type 2, you were much older. But now, unfortunately, children are getting type 2 diabetes. One, because of our diet. One problem. What do children do now after they have dinner? They're on their computers. They are playing with videos or whatever. When I was a kid, we didn't have that. So our big deal was all the neighbor kids would go outside, we'd ride bikes, you play ball, you're exercising. Our children now don't get enough exercise, and that's why they're saying that our children are getting type 2 diabetes, which is a huge problem. Obesity is becoming a huge problem. Isn't it so much easier to just drive through fast food? When you think about it, it's so much easier than have to go home and make a meal. Well, unfortunately, it is affecting our children younger and younger. Now, when you are 28 weeks pregnant, you are going to be NPO. You are going to go to the lab in the morning. You're going to drink 50 grams of glucola. Those of you who have been pregnant know how nasty that is. Then an hour after drinking it, they're going to draw your blood. If your GTT is elevated, they're going to have you come back for a 3-hour GTT. Your MPO, you go to the lab, you drink your glucola. 1 hour, 2 hour, 3 hour after you've had that, they will draw your blood. If you get too abnormal, congratulations, mama, you are now a gestational diabetic. You are now going to have a diabetic team working with you. Dietitian, diabetic nurse. What they try to do is diet first. Let's control your diet. I had a student that was gestational diabetic. She said, you have no idea how awful it is to count carbs every time you put something in your mouth. How many carbs can you have a day? How many of this? She said, I talked to the dietitian. She said, let's come up with a plan that you can tell me what I should eat in a day. She took that plan home and ate it every day until she had the baby. The same food every day. She said, I am sick to death of trying to figure this out. I'll just eat the same thing every day and I'll be good to go, which she was. However, if diet isn't working or you're non-compliant, common medication they could put you on is glyburide. Glyburide is a PO medication. We can try that. If that doesn't work or you are non-compliant, you're going on to insulin. Now you're going to have an insulin nurse. So, speaking of insulin, I got to tell you this story about a student I had in California. I worked full-time at this hospital, a co-worker of mine full-time at the hospital, and we heard of one of the colleges that we were familiar with looking for clinical faculty. We both applied for the same job. If you ever want to do that, it's called job sharing. I've known several nurses that have done this. For example, I don't always want to work in a hospital, so I'm going to work in a clinic, and then you work in the hospital when I'm at the clinic, or I'll work at the hospital while you're at the clinic. It's job sharing. So you're actually, two of you are applying for the same job and you trade off. And that's what we did. However, we both just did clinical. One day she had 10 students, one day I had 10 students, but we knew all of the students. On her day, big problem happened. We had a big high-risk unit. These were moms that had cardiac problems, preeclampsia, diabetes, renal failure, all of them compromised, or premature labor, all of them compromised because now they're pregnant. It was a huge unit, very high risk. They, number one, were not excited to have our students there because these women were at risk, but it was great education and we knew the staff, so we were able to get our students in. One particular day, the charge nurse comes around and sees a male student standing there with 2 syringes. She said, what are you doing? He had a major attitude problem. Well, what difference does it make? The only reason we knew all this is because the charge nurse documented this really well. I don't know. What difference does it make? I'm going to give this medication. No, you cannot give medication in this unit without your preceptor. Where is your preceptor? Well, I don't know. Is it my job to look for her? Is it my job to watch her every second? Yeah, actually, as a student, it really is. I couldn't believe this student was doing this. Neither could anybody else. So she said, what patient were you going to give this medication to? Well, I don't know what difference it makes, but right in that room right there, I'm going to give medication. She said, you are not. She said, don't move. I am going to call your clinical faculty. My coworker went over, it was Sean that day. She said, what's going on? The charge nurse said, or the nurse manager, I can't remember which one it was, said, your student here wants to give a medication without the preceptor. Joyce, you know, or she said, Lori was my coworker, you know, we're a high risk unit. So she said to the student, what medication are you going to give? What difference does it make? The patient has an order for medication. I'm going in that room. She said, would you please pull the chart for that room? And what were you going to give? Insulin. I'm going to give insulin. Show me in the chart where the order is. He pulled the chart for the patient that he was going to give insulin to. There was no order for insulin. My coworker looked through the assessment in the chart on the problem list. She was not a diabetic. She was there for cardiac issues. She said, you are holding 2 syringes. What's in them? Insulin. Well, how many nurses does it take to check the dosage? 2. That's right, Elizabeth and Tracy. Yes, 2. Well, I can't be responsible for where these nurses are when I need them, is what he said. She said, you are holding 2 3 ml syringes full of insulin. Number one, it's not in an insulin syringe. It's not by units, you've gone by mLs. She said, if you had gone in, thank goodness that charge nurse came around the corner. Had you gone in and given that because you know it all, you would have had a double homicide. You would have killed her instantly and that unborn baby. That would have been a double homicide. She said, there's the sharps container right there. Dump those 2 syringes in there right now while I'm watching. Go change your clothes. I will see you with Joyce at the dean's office tomorrow morning. We went in. He was released from our program. It was the second near miss where he could have killed another patient as well. He was a danger to the nursing profession. They put on his record that he should never attend any nursing program. Whether he ever did, I don't know, but he was released from ours. You know what, people? If you have a medication that you're not sure about, you really aren't sure, your clinical faculty would rather have you say, I can't figure this out. Would you come and help me? Or talk to your preceptor rather than say, oh, you know what, I'm really sorry, but that patient just died because I gave the wrong dose or the wrong medication. People, it's just not worth it. Thank goodness somebody came around and caught that guy. It was so scary. It gave me chills for a long time thinking about that. Is your diabetes going to affect your baby's size? Absolutely. Macrosomia, glucose gets to the baby. Remember, insulin does not cross the placenta, so the babies get bigger and bigger, which we call macrosomia. They can be over 10-pound babies. The problem with these babies is they get hypoglycemic. So the first blood sugar you take on a baby right after birth might be a little higher, and then they're going to crash because their pancreas can't handle all of that. So they end up, and you could have an 11-pounder next to a 1-pounder in the NICU. Both of them can't maintain their blood sugars. You can also have a problem in the pregnancy with having a baby that is got congenital anomalies, like the lower part of their extremities don't develop. You might have a miscarriage or a stillbirth, hypoglycemia. When the mom delivers, a big problem for her is shoulder dystocia because that head is huge. CPD, cephalopelvic disproportion. Let me just show you what diabetes looks like in the pregnancy. This is fairly short, but it'll give you a visual on what it looks like.
Gestational diabetes mellitus. Gestational diabetes mellitus is a disorder during pregnancy, characterized by increased levels of glucose in the blood over and beyond the normal limits. Insulin, secreted by the pancreas, attaches to receptors in the cells, much like a key in a lock, thereby opening up the cell for the entry of glucose. The energy provided by glucose entering the cell allows the cell to perform its functions effectively. In gestational diabetes mellitus, the placenta secretes hormones which interfere with this insulin uptake by the cells. This results in increased levels of circulating glucose in the bloodstream as compared to the normal levels of circulating glucose. Complications associated with gestational diabetes in the mother include 1. Hypertension. 2. Premature birth. 3. Need for a cesarean section. While complications associated in the newborn include 1. Macrosomia or increased birth weight. 2. Hypoglycemia. 3. Jaundice. 4. Breathlessness. The condition usually resolves after the birth of the baby. Treatment of gestational diabetes is aimed at controlling blood sugar levels within the normal range through healthy eating, as advised by the treating physician or dietitian, exercise, use of a glucometer to check blood glucose levels regularly, insulin administration if blood glucose levels cannot be controlled by the above measures.
All right, so that just kind of gives you an idea. I made up these algorithms for hypo and hyperglycemia. He is tired, which would be hypoglycemia. If she hit, I did for hyper, just something to reference you so it can be a little bit easier to figure out. I'm not going to go to the next screen quite yet. I do want to talk about screening, which we already talked about with the glucola. I got to tell you, these women are a lot of work when they come into labor and delivery. They are one-to-one care. Some of their screening that they have to do during labor is you are now going to antepartum testing 3 times a week for a non-stress test. Once a week, they'll do an ultrasound to see how big that baby is. And is the baby getting enough of what it needs from the mom? We will do her blood sugar as well. Now, if you are a diabetic that has now gone on to insulin, you're going to call your nurse every night, tell her what your blood sugars were during the day. She will tell you what your next day's sliding scale should be. Now, when you come into labor and delivery, though, you are one-to-one care. We had 8 order sets in California for a diabetic. If she comes in to be induced, you have 1. Once she gets into active labor, you have another one. And that one was a lot because when you hit active labor, you're 4 centimeters, right? Now we do blood sugars on her every hour until delivery, every hour. So every hour you're poking a different finger, getting her blood sugar. We took a copy of that order set, attached it to the pole on our IVAC. Every hour you stick her finger. You have another nurse come in. Here's the glucometer. This is what it said. Here's my order sheet. I have to increase the insulin by this. Watch me do that. Then I would chart and she would chart because it's 2 nurses. It was a lot of work. Then when they get into transition phase, you're going to do something else. If we go to a C-section, you do this. If you are a gestational diabetic, your blood sugar checks stop when the baby comes out. Now the baby goes onto the protocol of blood sugar checks. If you are type 1 or type 2, we will continue to do blood sugar checks on you in postpartum. But no matter what type of diabetes you had, the baby is on protocol as well. So we are monitoring for hypoglycemia. Now, one thing I need you to know, under where it says monitoring during pregnancy, it says the measurement of glycosylated hemoglobin A1C. How often do we do an A1C on diabetics? How often do we do them?
Every 3 months?
Yes, that is right. Good, good job. Remember, every 3 months. We check this routinely when a mom is 28 weeks, we do the glucola deal. Now, on an A1C though, I want you to know, is this a urine or a blood test?
Blood.
Blood, that's right. You can check her urine to see if she's spilling glucose, but for a result of an A1C, it's a blood test. You'll also note there that A1C of 6%. We don't want it higher than that. If it's 6%, we know she's in good control. So please pay attention to some of that. So should you see it again, it is every 3 months. We start checking at 28 weeks. A1C is 6% or less. They want to keep actually lowering that percentage. Pretty soon we'll all be diabetics if they get it too much lower. But just so you know, I want you to stick with the 6%. All right, I did not want to show this next slide too long in case you had other people, but let me show this to you. Oh wait, not this one, sorry. All right, we've talked about her nutrition and her exercise. Oh, one thing I need you to know, are your insulin needs going to increase or decrease during the pregnancy? Increase, that is correct. And how I want you to remember that, your body is getting bigger with a baby. It's going to demand more insulin if you need it. If she has a pump, we're going to help her with that. For some reason, my little picture did not come. Oh, there it is. All right, so this is a pump. For obvious reasons, I won't stay on this for long, but we want to be sure that we monitor our moms during the pregnancy. All right, we have talked about cardiac, we have talked about diabetes. The last short sentence or topic that we're going to talk about is renal and UTIs. This is under number 24 in your outline. You know, your ureters do dilate because of progesterone in the pregnancy, which can cause stasis of urine to happen, which can cause a UTI. You can be spilling glucose in your urine, a great medium for an infection. It feeds well, it grows organisms. We don't want that. Also, we have reflux that can happen, which you can develop a UTI. What are symptoms of a UTI? Frequency, pain. By the way, how do you know if a woman is having pyelonephritis? how would you simply be able to check her to see if she complains of a bladder infection? How do you know it's gone into pyelonephritis?
Fever.
She could have a fever for sure. Another easy way, which is should be on your outline, hopefully, is to palpate over a kidney. Gently palpate on a right, on a left. The right doesn't hurt. Ow, that hurts on my left. That is a classic sign of pyelonephritis. She'll have to go on to an antibiotic to get rid of that. We're going to do a clean catch on these women and give her an antibiotic, which is safe. Ampicillin, amoxicillin, cephalosporins are all right to give during pregnancy. What is not safe are sulfa drugs. They're okay early in the pregnancy. They're not okay later because it causes a binding of bilirubin, a binding of bilirubin, so the babies may have to go under the lights. You never want to give tetracycline during a pregnancy at all because it can cause bone growth restriction and ruin their teeth. So never give a mom tetracycline, and later in the pregnancy, don't give her sulfa drugs. All right, we're going to ask her to increase her fluid. Let's flush the body out. Let's get that fluid going, which would be a good thing. We've talked about that last week when we talked about nutrition. We're going to wipe from birth to death, ladies, front to back. If you have a baby girl, front to back. Daddies, you change your baby girls front to back, from birth to death. This is sort of a terrible thing, but sometimes when you're in a public bathroom, you see under the stall women that have their legs way far apart. You just know they're wiping back to front. You want to knock on the door and say, don't do that. It's front to back, front to back. Or you want to talk in the crack of the door. No, no, no. You want to tell her and educate her, because you're going to get a UTI, girlfriend. You don't wipe from your anal area across your urethra. Just remember, front to back. We want you to void frequently. We want you to wear cotton panties, underwear, because they breathe better. They don't breed an infection. And also, after sexual intercourse, you don't need to throw the guy on the floor. You just need to get up in an hour or so, urinate, clean up, and be okay. Cranberry juice. They say drink cranberry juice. Well, that's true. One of my students asked yesterday, is cranberry juice really effective? Not always. Number one, it's got a lot of sugar in it. If you drink the ones that don't have very much sugar in it, I don't think they do much for you. But one of our nurses got in trouble because a patient said, well, now we know I have a bladder infection. Can I drink cranberry juice? The nurse says, yeah, drink all you want. It's okay. Nurse did not ask the patient, nor did the patient offer to tell her, well, I'm a diabetic. Patient came back a week later for a non-stress test, and she said, I love that cranberry juice. Her diabetic nurse says, what cranberry juice? Well, my nurse said I could drink cranberry juice all day long. That would be no. Her blood sugars were actually quite high. Nurse got in trouble for not actually doing a full assessment on her and talking to her about her diabetes. In any event, we want to be sure we monitor for that kind of thing. I don't know why I added so much extra stuff there, but there you are. Any questions for me about anything that we have been over today, or any questions about what's going to be on this test that you're doing? Please remember, it does close tomorrow night. It does close Thursday night, and not Friday, Thursday. Also, I will be at the school today at 3 o'clock. If you would like to join me, we'll go over anything that you may not understand. I'm going to record that and I will upload it to you tonight or first thing tomorrow. Any questions at all from me? I'm going to let you go really early today because I'd like your focus to be on this test, not our future test. So good luck to you, everybody, and I will talk to you later.
Thank
Bye.
you.
Take care.
Joyce, do you know when the next review will be? The one that you're talking about for this exam?
The third exam? Yeah, I'm going to be doing
Yeah.
that. I'm going to be doing that one on June, let's see, the third one starts June 26th. So I'll be doing a review June 24th for test 3.
Okay.
Sounded good?
At what time do you say?
I'm thinking 1 o'clock, but I never know. I may wait till 2 when people get out of SCE.
Okay. Okay, sounds good.
right.
Just wanted to plan for that.
All right, no problem.
Thank
Talk to
you,
later,
Joyce.
Carla. Bye-bye.